Next, we have Ma'am Vanita Pathak. Ma'am will be speaking on primary non-valve glaucoma drainage devices in secondary glaucoma. Welcome, ma'am.
Thank you very much, and I'm grateful and thankful to AIOS for this kind invitation. Why do we need GDDs? But basically because we have a group of glaucomas called refractory who are frequently not controlled with maximum medical therapy, Dimox as well, where surgical management with trabeculectomy, even with MMC, is deemed to be a failure or is anticipated to fail, or in those where TRABs have already failed. So why are they refractory in nature? Because they have more risk factors. Generally, they tend to have more inflammation, or they tend to have membranes growing over the angle, causing severe closure, or tend to have conjunctiva that is not virgin, and already scarred due to previous surgery. Or it may be a combination of all of these factors. So why do we need? We need it for neovascular glaucoma, post-VR surgery, post-PK, aphakic, pseudophakic, post-trauma, eye syndrome, uveitic glaucoma, capro, the list is endless, actually. So why choose primary non-valve tube in secondary glaucoma? We all know that, one TRAB is done, it fails. Second TRAB is done, it may fail. I know people have done 3 TRABs, and then the patients have come to me, and then their tubes have also failed. So one has to give the best chance to the patient, because the first chance is the best chance. So tubes tend to have poorer outcomes if multiple TRABs are done. This is something I think we need to understand at a much deeper level. And valved GDDs, MA glaucoma valve the uptake of it is quite a lot in our country, but non-valve not many people are doing. They tend to have IOP, which is controlled again with AGM, anti-glaucoma medication, and there is a talk on ocular surface disease, and more use of anti-glaucoma medications is causing ocular surface disease, red, watery, teary eyes, which we are ignoring. These are the causes for failure of any future surgery. So more failure is expected from valved GDDs. The non-valve tubes available in India, from 2013 was the Orolab aqueous drainage implant, which is indigenous, cost-effective. Design inspiration is the Bowell 350 millimeter square. Now we also have another one called ClearPath. Both of these have initial hypotony, which you need to preemptively manage, and the resultant initial hypertensive phase prior to suture autolysis should be managed or with fenestration, stents, and even orphan TRABs. So this is, on the left is a Bowell, on the right is Adi. They're pretty similar, 350 millimeter square. Because it's a large plate, end plate, you have to put it under the muscle. The ClearPath has 2 models, 350, which again needs to be put under the muscles, and the 250, which is becoming pretty popular now, is because it can be put in between 2 muscles. How does it drain? Thin fibrous capsule formation around the plate happens around 5 to 6 weeks. You've ligated the tube, please remember that. This acts as a reservoir. Aqueous pools in the potential space between plate and capsule, and it passively diffuses out and is then absorbed by capillaries and lymphatics. Therefore, it is suggested that IOP reduction is dependent on the surface area of capsule formation, which is directly proportional to the end plate size and to the thickness of the capsule. So lower postoperative IOP is expected with a thinner capsule and larger surface area of this thin encapsulation. So let's have a look at some of the surgical technique. You basically need to dissect out the adjacent recti, then you take the plate, you occlude it, and you use some fenestrating vents anterior to it. You can even use a vicryl stent, and before placing the plate under the muscles, or you can use a ripcord. Basically, you reduce the size of the lumen so that when suture autolysis occurs at 6 weeks, then you do not have a precipitous hypotony, which is what most people are worried about. And you prepare the plate similarly. You occlude it, then you place fenestrations, and then you place it under the muscles. I typically place these 10 millimeters posterior. So the new one, you can see now that the incision is so small, it's only 5 millimeters, and I'm about 4 to 5 millimeters behind the limbus. This is the Ahmed Clear Path 250. Again, the plate is prepared very similarly, and in these, a 40 Proline ripcord comes pre-placed, so you don't even have to procure it separately. And so you occlude it. Here, the first occlusive ligature did not occlude it completely, so I used another one. And at every point, I check. I check for occlusion, and then I check for filtration anterior to the occlusion. So here you can see, that you can actually fold the tube. I'll show it to you again. You can, no, this is the other slide, sorry. How 7 minutes disappear, you don't even know. Yeah, so you fold like a taco. You fold the tube. I don't know if you remember doing foldable implants. Initially, we didn't have injectors. So you fold and you go through that 5 millimeter incision and you just let it unfold inside. And it's in between muscles. So it's, in spite of it being a very invasive surgery, and very fortunately, it is not that invasive. And once you have placed the plate and fixed it, the surgical procedure is very similar. I typically place all my tubes, especially in pseudophakic and aphakic eyes, in the ciliary sulcus. The reason being that it prevents tube endothelial touch and endothelial cell loss over a period of time. So there are very few studies that have been done in India comparing or, based on tubes. But there are RCTs that have been done in the West, and they have looked at Bauwelt versus Ahmed glaucoma valve, the valved one. None of the studies have actually done it in primary glaucoma. So I just want to briefly share with you the results of my series of ADI in primary glaucomas. ACP was introduced very recently, and unfortunately, I don't have the follow-up yet. So these are 59 ADIs, all are primary tubes in secondary glaucoma. And as you saw, the NVG and the VR surgery group was the highest. Here you can see preoperative IOP was 36, and it reduced to 13, a whopping 64% reduction. Failure was in about 8.5%, and most of it was because of explants. And the explants happened mostly in eyes where conjunctiva was very scarred due to VR surgery. Then anti-glaucoma medication started with 3.8 and reduced to 0.9, a 76% reduction, and success rate over 3 years, 92, 90, and 82%. Complications, anything less than 50% in tubes is actually excellent result. And interventions, only about 15%. And there was no incidence of serious complications, no loss of vision. So I will end by saying tubes are indicated in refractory glaucomas, where failure of trab also is anticipated. More manipulations are required in non-valve GDD to keep IOP under control. And this initial hypotony, which is expected, should be managed preemptively, and only your meticulous technique will avoid this. Resulted initial hypertensive phase should be managed the way I just showed you. So greater understanding of the non-valve technique helps to minimize incidence of safety-related adverse events. Like I showed you, complications were not that many. Preempting complications and planning countermeasures lead to optimal outcomes, and particular attention needs to be given to the length of the tube and its placement. It's well worth the pain for the gains that you get. Thank you very much.
Thank you, ma'am. I think it was a very enlightening talk, and we got to know about the most recent devices that are being just started, I would say. So thank you for enlightening all of us.
April this year we started using it. Thanks.
Thank you.